Welcome and good morning or good afternoon, depending on your location. My name is Dr. Conrad Duncan, and I want to thank you for tuning into this product theater this morning. I would also like to thank the SGS and Neomedic for sponsoring this forum. And a housekeeping note, this discussion is being recorded so that you can feel free to download and review at a later date if you'd like. My email is listed, so please feel free to send me any questions or comments that you might have that we don't address during the talk or don't get to in our question and answer period. We hope to leave 3 or 4 minutes at the very end for fielding your questions and comments. Some of you in the audience are experienced users of Anchorsure, and we would love to have and hear your comments or suggestions regarding your clinical experience and maybe tips or tricks that you've picked up during your clinical use. Please submit your questions using the Zoom format, which I'm sure we're all familiar with at this time. The abrupt removal of synthetic mesh kits from the pelvic floor prolapse space in 2019 left many pelvic surgeons exploring for other options for apical fixation in an effort to maintain the safety advantage of vaginal surgery. This product theater will introduce, or for some of you, review a safe, simple, fast, and relatively inexpensive apical fixation technique. A video link will be provided, so if you'd like to view a complete surgical procedure utilizing Anchorsure, you'll be able to do so at a later date. The Anchorsure system is supplied with a trocar and applicator, which is viewed in the center, with a preloaded anchor with 0 proline suture. It also comes with a free needle, which is of approximately the SH size. I personally switch out this needle and utilize a CT1 or larger needle, free needle, when I'm placing the suture into the cervix. The needle that comes with the kit is excellent for passage through graft material or through vaginal epithelium, but a more robust needle is sometimes needed for the cervix. The anchor comes supplied with a 0 proline suture, and this can be changed out to a suture of surgical preference. When I do a 4-point procedure, I generally will use 2 long anchors or long applicators so that there's always an anchor loaded and ready to be used or deployed. The anchors are made of polyether ether ketone. This is a biocompatible material often used in orthopedic surgery as a spacer. The actual size of the anchor is viewed over to the left in comparison to the tip of a ballpoint pen, and you can actually see it's very small. The pull-out force of the anchor has been measured to be greater than 50 newtons, and in practical terms, this is about twice the value of what is deemed as physiologically relevant in the human body. As mentioned earlier, the anchors are compatible with switching out to other sutures, PDS, silk, or Gore-Tex. I've not personally used any Gore-Tex, so that if there's anyone in the audience who has used Gore-Tex with the Anchorsure, I would like to hear from you at the end. We would like to hear from you at the end of the discussion. My thought is that I would take a 2.0 Gore-Tex and 0 would not fit through that eyelet, but again, I do not have experience with Gore-Tex in my clinical practice. This slide shows the profile of the anchor when compared to Capio or Capio-like devices. It is important to know that it's not just the profile, which is of importance, but it's the tactile minimal dissection needed to apply the anchor compared to visualization of the sacrospinous ligament needed for freehand suturing or placement of a Capio device. My clinical experience to date, I've performed over 1,000 repairs utilizing Anchorsure with over 3,000 anchor placements. We've had no intraoperative or immediate postoperative complications directly related to the anchor. I've had 2 anchor extrusions at 9 and 11 months. They were both handled in the office with removal. I believe these were secondary to poor placement. These were earlier cases, and I have since moved to, if I'm unable to get an excellent purchase or placement into the sacrospinous ligament, placing into the iliococcygeus fascia. I can't for sure say those cases were that, but I believe they were. The mean operative time for the last 50 cases has been 112 minutes, but of course this time is of little importance when considered all variables, including whether a hysterectomy was performed, graft was used, whether it was multiple compartment or a sling procedure performed. I find a more genuine time of savings provided by the Anchorsure would be measurement of first incision to placement of first suture. I have not actually measured this time compared to other methods of applying a suture, but it sounds like a good project for any fellows that might be listening or tuned in today. This slide demonstrates the actual anchor placement in a model. You'll notice on the left-hand side that the anchor is somewhat parallel to the floor or vaginal canal. When I actually place my anchor, I generally will stand and place the anchor in a perpendicular position to the floor. So the trocar is more perpendicular to the floor than parallel. I believe this actually adds an extra layer of safety and prevents the applicator from sliding off the sacrospinous ligament. It also allows you to know that you have an excellent foundation and firm placement of the anchor onto the sacrospinous ligament. To the right on this slide, you'll notice that the anchor can travel approximately 11 millimeters, and then it cannot travel anymore. This is built into the system in order to prevent the surgeon from actually placing the anchor through the sacrospinous ligament. In the middle picture there, you'll notice the same 11 millimeters at the beginning of the trocar on the opposite end. This is in its loaded or pre-deployed state. The picture to the left demonstrates the anchor having been placed into the sacrospinous ligament and the pulley motion that is obtained similar to any other suture placement into the sacrospinous ligament. In addition to the depth of safety, the Anchorsure delivers a distinct pop when applied to the sacrospinous ligament. The pop and the tactile feedback from your blunt dissection finger or blunt dissection index finger, again, adds a level of safety and feedback to ensure that the anchor has been placed in the correct position. The beauty of the Anchorsure, again, is its simplicity and ease of placement. This picture demonstrates the suture placed through the sacrospinous ligament via a suture delivery device, or if it were a freehand placement. The placement in this picture certainly represents an excellent fixation and provides the pulley action that we use. But there's also entrapment of tissue, which is completely avoided with the Anchorsure device. Anchorsure is a true tactile surgical procedure. Essentially, it's blind surgery when placement of the anchor, because your index finger has bluntly dissected to the sacrospinous ligament with excellent feedback, and the anchor is placed right next to that dissection finger or over top of it to ensure exact placement of the anchor. There is less volume of surgical dissection involved with the simple blunt dissection of one finger. To the right, you'll notice two Breisky retractors utilized before we had this system in order to visualize the sacrospinous ligament. You can obviously see the volume of dissection to utilize retractors is much greater than the volume of dissection that would be utilized just for an index finger. This use of Breisky's or Richardson retractors is completely unnecessary during the placement of an anchor. Almost all repairs are performed as a same-day procedure, and I have actually done 2 procedures under local with IV sedation. This lends itself to excellent use for surgical centers and for patient convenience. Most patients are discharged without the use of narcotic medication, and this is probably secondary to the decrease in surgical dissection volume, decreased surgical time, and less tissue entrapment. A randomized controlled trial is currently underway at Wake Forest under Catherine Matthews, comparing pain with the Capio device and the Anchorsure system. The primary outcome being measurement of pain in the buttocks and posterior thigh at 1 and 7 days and 6 weeks. The Anchorsure is extremely versatile and can be used from an anterior approach to the sacrospinous ligament or posterior approach, unilateral or bilateral. It can be used in cases of massive vault prolapse. And I find the anchor especially helpful in these cases because visualization, as you know, in these cases is extremely difficult. And visualization of the sacrospinous ligament is not necessary for placement of the anchor. And therefore, these cases are extremely helpful to use the anchor in these cases. Again, the simplicity and speed is unsurpassed. The speed and lack of visualization can also be important in patients who cannot undergo Trendelenburg positioning for long periods of time. Again, I'd like to remind you that the suture can be replaced to whatever you prefer, and the Anchorsure system can be used with or without scaffolding. Anchors can be used for 4-point apical suspensions, especially useful in hysteropexy. And the anchor can also be deployed into the iliococcygeus fascia if the sacrospinous ligament cannot be palpated, or if there's scarring in that area from previous surgery, or if the surgeon feels more comfortable with that placement. So this completes our presentation, and we should have time now to review some questions and comments that were sent in during the talk. Thank you for your attention and look forward to discussion. Great. Thank you. I think we have about 3 or 4 minutes for questions. I received a great question from Dr. Clayton, and it's one I hear frequently, and it concerns the need to remove an anchor if it's not placed correctly or you place in the ligament, and sometimes during the pulley motion, the suture can actually break. And the concern is there's not much in the literature regarding this issue. And that's absolutely true. And I have left many anchors into the ligament with breakage of suture. Sometimes on my Hulk days, they do break. You have to be very careful. But leaving them really has provided no issues for patients. I mean, we have to remember we leave things in the body all the time, including mesh, sutures, bulking. And the fear of placing into the ligament is probably less concerned than placing it into soft tissue, but I've had no issues whatsoever with leaving the anchors in place if it's not being utilized for actual pulley. And remember, even once it's placed correctly, it's left in place permanently. So I think the size, the biocompatibility makes that a non-issue, although it's a great question and there is no data in the literature to tell us what to actually do. I do not, under any circumstance, would recommend digging after that suture. Okay. I don't, there's a question here regarding the device compared to FemSelect, and I do not have any experience with that. And so I don't, I think the tactile feedback, I do believe the FemSelect comes with a device to guide the placement of the anchor. If I'm correct with that, I think the removal of the tactile feel of the sacrospinous ligament is not a benefit. I think there's great benefit in palpating, feeling, and actually feeling the pop of the anchor go into the sacrospinous ligament. But I don't have any experience with that device at all, so I can't really speak to a head-to-head comparison. I've had a question concerning about placement of the anchor into the uterosacral ligament. I don't recommend that simply because it's a little soft. Placing into the uterosacral ligament, there's no backdrop to actually get that pop of the anchor in. If you're looking for a soft tissue placement, again, I would recommend the iliococcygeus fascia for that. And I think we're probably maybe have time for one more question. Vince, did you have a question? I see you're popping up and maybe ready for the next talk, but let me just see here. Vince, are you there? The question about hysteropexy. Of course, the device can be used with hysteropexy. It is, I generally will do a 4-point suspension when I do a hysteropexy, and a bilateral suspension only if there is no uterus involved. Thank you for your time.